Hey there, everyone. Let's continue our conversation on neuropathology conditions. Okay, our next one is ALS, amyotrophic lateral sclerosis, also used to be known as Lou Gehrig's disease, and you'll still hear that occasionally. Okay, so ALS, we still don't fully know what causes this. There's some genetic mutation component and there's some risk factors, but we still don't fully understand this condition. Epidemiology, men are more affected than women, for sure, and I do want you to know that. It's more common among white males and non-Hispanics. Typical age at onset is middle age to later, so that's 55 to 75, although sometimes you get it in teens and the very old. Line of work is a risk factor, specifically military veterans. We have literature that tells us that military veterans are 1.5 to 2 times more likely to develop ALS than the general population. They still don't fully know why this is, but they think it's an exposure thing. So veterans are more exposed, especially if you have service out in country, to pesticides, environmental toxins, lead, and things like that, to the point where the U.S. Department of Veterans Affairs, the VA, recognizes ALS as a service-connected disease. I have not treated this condition very much, but all of the patients I have treated with it or met had a service record. So yeah, there's definitely an environmental component if that's the case, right? In terms of presentation, it's an upper motor neuron and a lower motor neuron condition. So this is a mixed central and peripheral condition. It is, interestingly, the most common adult onset motor neuron disease. And because it affects the central nervous system and the peripheral nervous system, it has signs and symptoms of both. So your lower motor neuron signs include muscle weakness, atrophy, fasciculations, hyporeflexia, and hypotonia. Remember that fasciculations are a really classic lower motor neuron sign. It also includes upper motor neuron signs such as spasticity, clonus, hyperreflexia, and pathologic reflexes, remembering that clonus is a really classic upper motor neuron sign. Okay, so how do they look outside of the upper motor neuron and lower motor neuron signs and symptoms? Well, a lot of other issues that are kind of cranial nerve-esque, as well as just general regulation, such as changes to urination, pseudobulbar effect, difficulty with respiration. They have issues with chewing, swallowing, and speaking. And then they also have a really hard time controlling because they can't swallow properly, the saliva builds up in their mouth and they're prone to excessive drooling, such that it's an actual issue for the saliva, causing issues around the skin near the mouth. So it's not unusual to meet someone with ALS and they have these red streaks or kind of like broken skin at the corners of their mouth, and it's just from the sialorrhea, the excessive drooling. They're also very, very tired, especially earlier on in the condition, as they're starting to lose their mobility. So the onset here, this one's a little different. It's typically asymmetrical, very focal, and it starts at the ends of limbs. So the most common initial symptom is weakness to the upper extremity. A classic you'll hear is they start dropping things all the time. Oh, I keep dropping my toothbrush, my glasses, this cup of water, my TV remote. That one I've heard a couple times. Second most common site for the initial onset is the lower extremity, and third most common is the face, so bulbar weakness. Unfortunately, this is an aggressively continuous condition. In other words, it continues getting worse. So it starts with one thing and it builds from there. Functions that aren't affected include sensory, bowel and bladder in general. So when the excessive urination is more of an autonomic thing rather than the actual motor functioning of the bowel and bladder. Eyes are unaffected and the heart is unaffected in terms of its neuro. Cognition is also typically spared. Unfortunately, though, this has a very poor prognosis. Typical life expectancy after onset is only 3 years. It tends to take out your respiratory capabilities in a powerful way, and that tends to do it. It goes better if you're younger at onset, although of course that's awful. If there's an initial onset of issues with the face, muscles of mastication, the tongue, or respiratory, that's a very negative prognosis factor. And I just have a thing here from a particular paper looking at this condition just to give you a sense of it. So observe the tongue here, these lines here, and kind of how it's like there's a plateau and then there's a little heart shape there at the end. That's atrophy. And then along here, that's also atrophy. Okay, so this indicates a bulbar onset. Okay, this is cranial nerve stuff here. The tongue is cranial nerve in its function. And then here is muscle wasting, serious atrophy. So they sometimes call this flail arm syndrome. You don't have to know that for me, but this shows the lower motor neuron features and that there's a lot of muscle wasting. So how do they catch this? Well, they can do peripheral nerve testing, and that will typically demonstrate it. There are only 2 medications approved to treat this condition. 2, that's it, yeah. The main one is Rilutech or Riluzole. It's very expensive. The way it works is actually quite fascinating. It reduces the activity on a chemical level of the lower motor neurons and thereby prolongs your survival, which is really fascinating. But that's really all that you've got. Otherwise, they're kind of just managing symptoms to make you more comfortable. Let's switch over to another one. This is a peripheral condition, okay? This one is a virus called poliomyelitis that infects the lower motor neurons specifically. It likes to take out the neurons in the spine. One of the more famous individuals with this is the American president, FDR, Franklin Delano Roosevelt. So if by looking at him you can tell that there is a paralysis associated with this condition. The presentation is often asymmetric, and it's a powerful paralysis, usually resulting in flaccidity. In other words, there's no muscle activity whatsoever. It tends to affect the legs more than the arms, back when it was a thing. Due to a lot of different forces, this is actually coming back in some areas in small amounts. Otherwise, it was originally completely eradicated in the United States, and it was on its way out worldwide, but we've seen a small flare of it in some areas. The vaccine has been around since before all of us were born. So that's the original poliomyelitis. And the original infection is important to understand so that you can understand the condition we're actually going to discuss, post-polio syndrome. So in the initial infection, the presentation was determined by how many motor neurons were affected and how many were able to recover. A motor neuron that recovers tries to take up the slack of its fellows that died from the infection using a phenomenon called collateral sprouting, in which the original the original motor neuron sprouts new axons to reinnervate muscle fibers that were left hanging from the death of their original motor neurons. So you can also just build up the strength of the surviving muscles and motor units and get some hypertrophy that's useful. So that's the original. So when this person was infected, and it almost always affected children. This was a horrifying disease back in the day, and for those who get it now, it's still horrifying. So again, remembering that this is a motor unit, okay? So a motor unit is defined as a motor neuron and all of the muscle fibers that it innervates. So an entire muscle is the product of, say, like its activation is the product of, say, 3 motor units. So if you lose these ones here in red, then gray and pink will sprout and try to take up the slack. So this is what they think happened. So this was the original infection. You had acute polio and you lost a lower motor neuron, okay? So you see here, sprouting a new axon and taking up the slack. However, natural human aging, we actually lose our motor neurons, but this effect is magnified in somebody who already lost motor neurons in their youth due to polio. So post-polio syndrome is basically an acceleration of that, in other words, a magnification of the effects of lower motor neuron death due to typical neurologic aging. So basically, they're already playing with fewer neurons, and so when they lose one, the effect is stronger. So the hallmark symptom, therefore, of post-polio syndrome is new weakness in somebody who has a known history of polio, and this weakness tends to hit the muscles that were weak at the initial infection, okay? So about a third or so of your patients who survive will experience this, and it's usually way down the line. I've only seen this a couple of times. Actually, I think I've only seen this 3 times. It's getting pretty rare because the initial individuals affected with polio are passing away. But of those 3 individuals, all 3 of them had pneumonia. And from the pneumonia, it's almost like it just kind of aggravated something. These patients were in their 70s and 80s, and it's like it came back. It was quite awful to watch how upset they were. It was a strong level of anger that they had. So how do they look? Again, the fatigue, the new weakness, probably in muscles that were originally affected. They tend to have quite a bit of joint pain and muscle pain. Like I said, new respiratory difficulties. That's probably how they got the pneumonia in the first place. Boy, they get cold. Oh my gosh. Because, hospitals are cold. They'll try to put every blanket they can on top of them. Serious cold intolerance. And it steadily progresses. So once it starts setting in post-polio syndrome, it's progressive. So what's really frustrating too for these individuals is that there's a greater risk of post-polio syndrome if their initial recovery showed a lot of like aggressive rapid return of function after a really rough initial presentation. In other words, if the polio affected them severely and then they got a lot better. So if they were wheelchair bound and then got out of the wheelchair, that's dramatic. So the reason they were able to get out of the wheelchair is likely extensive collateral sprouting, which at the time was a really good thing. However, these massive motor units that they built up are part of why they're getting post-polio syndrome, which is so awful, right? They fought for that recovery, and now they're regressing. So medical management here is basically non-existent. There's nothing that can slow the progression of it, so the management is basically rehab. It's therapy in reverse, if you've heard this phrase before. This is physical therapy that we do for a patient without an expectation of them actually getting better. Our hope is to maybe slow the progress, but we're not going to win. In other words, we're not going to freeze it in time even. It's going to keep getting worse, so we help them manage as they keep getting worse. As I'm sure by this point you can tell, this is a psychologically angering disease. All 3 of those patients that I saw when I was hospital side with post-polio syndrome that was brand new, they were angry. In fact, one of them threw me out of the room. The very first patient I had, they wanted desperately to get up. It was in the exact same presentation as their initial infection. This man was so angry, he would yell if I was moving too slowly in the room. He would yell if I tried to help him too much. Mind you, he needed an assist level of me of in excess of 80% to sit to stand. He could not fire at all, and he was so upset. He would cry during therapy. His wife was beside herself. They were both yelling at me. I finally, after a few minutes of this, had to tell them, that is not going to help. You need to treat me better. And they then threw me out of the room. A couple hours later, they paged the nurse to apologize to me and just explained that they were very frustrated and they didn't mean to treat me that way and things like that. And I was like, I've read about this in school. You're actually the first person I've seen with this condition. It makes sense that you would be angry. Let's be a team and, let's get to it. And then treatment went fine. But this is just to give you a slight warning that the psych presentation on them. Think about who actually recovers from polio. You have to force your neurosystem, your neurologic system, to build those collateral sprouts. That requires high intensity. So folks who recover from the initial polio infection are A-type personalities who are, I call them winners. There's a reason they got walking back, because they worked very hard. So to lose it, to be vulnerable like that again, that's powerful in a negative way. So you really need to build that therapeutic alliance with them. And the second 2 patients I had, I would say I did a lot better as a vessel. The first time I wasn't, I don't remember learning in school that they tended to be angry. So I imagine at this point, I was in school 10 years ago. I imagine at this point there are fewer of those cases, but you might see some, especially if you're getting folks who are coming in from other countries where they haven't had the vaccine. But those would probably be younger folks. All this is to say, just be ready. If you have an older patient, post-polio syndrome, they might be angry, and counseling might be a really good source of care for them, because there's not much science can do, unfortunately. Let's kick over to multiple sclerosis. Okay, you've probably heard of MS. This is actually a pretty common one. This one tends to affect women more than men at a much higher rate, 2 to 3 times. In fact, I think at this point I'm still in single digits on the number of men I've treated with this. It's definitely double digits for women, and it was that true within a year or 2 of me entering the clinic. Most commonly, it starts in young age. So those of you listening, if you're in PT school, you're in the risk age. In fact, you've probably just entered it, age 25 to 35. It has a geographic prevalence. Individuals in the northern regions, note from the maps here that the areas with highest risk in the red are at the edges of the globe. So the logic here is that it's more likely to occur if you are in a cold area. So you can even see in the US that's true as well. Etiology, mostly unknown, although that's starting to change. It's likely multifactorial. You do have a genetic risk. If you smoke, it's much more likely to spread MS and make it more aggressive. I remember a gentleman I had with it could not seem to succeed with cessation. He tried 3 or 4 times. His MS was very aggressive. It was kind of scary aggressive, actually, and he kept having relapses. However, you're in luck. You are entering the profession right as we have a form of knowledge. In 2023, there was a massive and brilliant study that I have linked on your supplemental Canvas materials, which implicated specifically Epstein-Barr virus as a leading cause of multiple sclerosis. For I can tell you more about this when we get to class, but basically, they had people who had never had Epstein-Barr and did not have MS, then got MS, they took a look at antibodies and found that Epstein-Barr virus antibodies were present, and they were able to implicate specifically EBV as a leading cause. So the presence of Epstein-Barr virus antibodies increased the risk of developing MS by 30-fold in this study. It's an absolutely brilliant article. It got published in Nature of all things, right? Kind of the highest level. But all this is to say, now that they realize that Epstein-Barr virus is a huge source of multiple sclerosis, after this paper came out, there is now research into developing a vaccine for EBV. EBV is basically a cold. It's an upper respiratory infection of little to no note, but for a small percentage of the population, it's quite serious. So now they're thinking if they can build a vaccine against this, you might eliminate a lot of MS. Team, we will probably live to see that happen. So that's very exciting in MS research. Okay, so what's the pathophysiology here? This is kind of the central nervous system version of Guillain-Barré. So this is an autoimmune attack of your myelin. However, this occurs in the CNS. Unlike Guillain-Barré, this comes in rounds and it's for the rest of your life. Guillain-Barré is a one episode thing, one infection and you're done. MS is for keeps. It's chronic, it's potentially progressive. So you have these recurrent bouts of an inflammatory process causing autoimmune damage to your axons, to their myelin. And once that autoimmune flare goes down, then the body remyelinates. So earlier on in the disease, that tends to mean that you'll drop in function and come back up. So when you drop in function, we call that a flare. The remyelination occurs and the axon reachieves its normal function, and then you kind of come back up. So you go down and then you relapse and come back up. However, over time, you start to build scars onto the axons, and myelin can't rebuild over that. So persistent demyelination in the super long term eventually causes permanent axonal damage, okay? So the pathophysiology in the long term is important to know. Again, this is a chronic issue with an autoimmune component, and over the decades, because you're losing synapses, you start to lose brain volume. Observe, this is part of the pathophysiology, okay? So this is actually showing astrocytes. Remember that astrocytes are part of your scarring machinery in the brain. And as you can see from A to B to C, the scarring activity is much, much more active. These astrocytes, as they get more active to build these scars, are part of the reason that this condition gets worse over time, why it's considered a chronic progressive condition, even though it can seem like, oh, but it gets better. Yeah, that's earlier in the condition. Later, when they hit more of a geriatric age, then it becomes more of an issue with the relapses not getting better. You don't need to know the specific slide, but I think it's interesting to note because it's not unusual to have people who think that they have MS, but the physician says no. What they're probably in is what we have over here. So this is called preclinical MS, right? And it's got a lot of different names. But basically, you're having injury, but it doesn't show up yet. Okay, so that's this territory right here. I'm not asking that you know this. I'm just demonstrating to you that it takes a while before it actually is caught by physicians. So you can have patients who look like they have an MS and don't have a diagnosis. Yeah, really frustrating, right? And again, remember, this tends to affect young women. So sexism in medicine is real and their complaints are not taken seriously. Eventually, a person probably ends up with this, relapsing remitting. And what tends to happen is they get worse, then they get better. So this way is getting worse. This way is getting better. So they get worse, then they get better. They get worse, then they get better. But then remember, over time, the scar tissue builds up, right, inside the brain, which means that they get worse and then they don't get as much better. Look at how much better this is compared to this. And at some point, they're really not getting much better and it just keeps getting worse. And at that point, the condition converts from relapsing remitting to secondary progressive, in which it just keeps getting worse, okay? Again, remembering this direction is disability. So you don't need to know the specific slide. We're going to jump into it more here. Okay, at this point, I'm going to pause and we'll kick over to part 3.